Awesome. Thank you. Can you guys hear me okay? We're going to get started, and you're going to hear from Julia, who's an MBC patient, and you're going to hear from Dr. Lehman, who works at MD Anderson. And with that, I'm going to let Julia get started. Again, it's just an honor to be here, and I think the biggest thing I want you all to know from my point of view is just the amount of people working together for you. I work at Baylor College of Medicine, and we have a speaker from MD Anderson, and YSC and Teresa's Research, and there's so many other organizations that are here, and we're all working together for you. So with that, Julia.
Hello. First I'll just thank Josh for inviting me to come here, and everyone that does not have metastatic breast cancer and is here, it is so emotional for me to think about the people in my life, from like my caregivers, my family, my doctor, people that do not have the illness and that still dedicate their lives to helping us continue living. So Josh is one of them. His mom had MBC, and when she was still alive, they founded this organization, and she passed away almost 6 years ago, and he's still dedicating his life to make the lives of people with metastatic breast cancer better. So he could have chosen to completely leave that world, forget that terrible thing that happened to him, but he's here. So that's really meaningful, Josh. You're very special. So you heard a little bit about my story. I was pregnant 25 weeks when I was diagnosed with breast cancer. I found a lump. We thought it was early stage, although I had a lot of pain in my chest and back, and people told me that it was just the pregnancy, and there really was nothing that could have been done differently because I was pregnant. I received chemotherapy while I was pregnant, some of the most toxic drugs there are, adriamycin and Cytoxan. When my son was born, he had a lot of hair. I had no hair. That made me feel good. I felt like the placenta did its job filtering some of the ugly stuff. He was very healthy. He was in the nursery when I was brought downstairs to get scans to finally be checked out, and I had extensive mets. My whole spine, my whole chest. My oncologist at the time gave me morphine right away because he couldn't believe I was still walking around. And I was walking around with a baby inside me. A few weeks later, we discovered I also had mets to my brain. I had mets to my liver. It was really bad. So I received HER2 targeted therapy at that point because that's my subtype. And I also had very bad heart problems from the chemo while pregnant, the pregnancy itself, the drugs after the pregnancy, and I was in the cardiac ICU for a couple weeks. We thought I was not going to make it, and I'm here. It is almost 6 years. So I don't want to take any of the time that Dr. Lehman will talk about the latest and greatest in MBC, but I do want to talk just a little bit about how each of us can play a role in getting to the latest and greatest. So yesterday, the first immunotherapy for breast cancer was approved. It's a triple negative drug that can be given to some patients with a special marker. So it's very hard to keep up with the things that are happening. I spoke with the Genentech rep, and I said, where are the flyers for the new drug? And he said, well, this morning when I set up the table, I didn't know it was going to be approved. So, it's really fast. And you'll see Dr. Lehman's slides don't have that drug because she submitted them last week, and that drug wasn't approved. So it's a lot that is going on, and fortunately, things are moving very fast. I'm sure Dr. Lehman is feeling the difference of how fast things are being approved and discovered from when she started training a few years ago. She's young. But how can you keep up with it? What can you control? So I'll focus on a few things. Do you have an oncologist or do have an oncologist that you trust and that you feel confident in. So not everyone lives in Houston and has Baylor or MD Anderson to go to, and that's okay. And many people go to a community oncologist that sees a variety of cancers. But do you feel like your doctor will know what he or she doesn't know? And are they humble enough to say, let's call the person that specializes in this exact subtype, and because you absolutely need this, okay? So we're very complicated. The people in this room are the ones that are going to need the therapy that are not standard most of the time. So we want the very specialized people to be thinking about our problems, and sometimes even some of the smartest people there are studying our disease have different opinions about how to approach a specific patient. So you want them to have an intellectual wrestling about what the best treatment is for you. So get involved and make sure that the right doctors are thinking about you. If possible, get a second opinion. I absolutely encourage people to do that. And if you're able to travel to an NCI designated institution, have someone there that will consult with your oncologist. If you don't live in a place that has an NCI designated institution, do that. Another thing is be connected with other people with MBC. I'm sorry, I take Herceptin type drugs, so my nose is running. So be connected with others that have MBC online, in person, over the phone. Many times, I have found out about drugs or trials from other people. Thank you. From other people. It's fine, as long as it's not blood. Sorry. From other people, just because they told me that they were on a trial, or their doctor told them that a trial was going to open up. So try to be connected to people as much as possible. It is impossible for us to be on top of all the things that are happening, and it is not your responsibility to be informed on the latest and greatest. But you will be the expert in you. So your doctor may know the most about your Her2 positive cancer with brain mets and blah, blah, blah. But you will know how you feel after the infusion. And you will know that something feels different. Or you will know that you usually have a headache if you don't eat for X hours. And you will know that something different is happening. So focus on that. And anyway, that's all I have to say. I have some business cards just with my contact information. I don't have any organization, but if you'd like to be in contact with me, I'm happy to talk to anyone. I told Terlisa, is she here? I told Terlisa yesterday. Terlisa Shepard is a person that has been living with MBC for 18 years, or maybe 15. Yeah. Yeah, and she has brain mets for that long. And when I first met her, she was pregnant when she was diagnosed. I cried because I thought she was a legend. I didn't really believe that she was real. And I told her, do you realize, when you were diagnosed, imagine if you had met you? And she's like, oh, okay, now I see it. So, 6 years is now a big deal. Feel free to ask me any questions, or I can possibly lead you to the right place. Thank you.
Good morning, everyone. Good morning. I'm very happy to be here. I have been at MD Anderson for 2 to 3 years now. Before this, I was at Ohio State, and always liked this organization. I think it's really important, and young women have to deal with a lot of really unique issues, so I'm really happy to be here. So I was tasked with talking about updates in metastatic breast cancer in 20 minutes, which I could talk about for 20 hours. So I'm trying to keep things very, very much an overview, things that no matter what type of subtype of breast cancer you have or what your situation is, some things that will help you as you're figuring out the best treatments and what to do. And then we want to give plenty of time for questions so we can delve into some more unique issues, or if you want to hear a little bit about some newer treatments that are coming out. I also didn't know that atezolizumab was going to be approved yesterday. It's really exciting. We thought it was going to be approved. I actually thought another drug, sacituzumab, would have been approved by now before this, but it's coming. That's what I hear. Just production issues. So it's day to day, there's new things all the time, and that's what's really exciting. I was talking this morning how I had in the fall, I had to retake my oncology boards. We have to do it every 10 years. And I've been dealing with breast cancer, and I had to study all these things for different other cancers. And I was so struck by how much has changed in the past 10 years for other cancers as well, and how what I learned 10 years ago was obsolete, which is a good thing because we're learning so much and we're making so many strides that it's really a really exciting time. So I'll go through these slides. So a lot of treatments that will be given will be standard of care, and there could be clinical trial options. Clinical trials aren't always the best option for every person or even a feasible option, but it's good to know what's out there, because what we do know is that every treatment that we're using today was once a clinical trial treatment. And so this is important for to develop new treatments and also to help future generations, as past generations have helped everyone here today. So what's probably the most important thing to know about breast cancer, and I really hope everyone knows this, is what these 3 markers are on your breast cancer. I'm amazed that sometimes I talk to patients that were recently diagnosed, they've already seen some doctors, and they don't know this information. And I'm surprised that I'm even having to go over this, but it's really important to know. So at this point, we are testing breast cancer for 3 markers: the estrogen receptor, the progesterone receptor, and HER2. Pretty much these markers are subclassifying breast cancers into better treatments. 20 years ago, most breast cancer trials were all breast cancers clumped together. And I think there were probably a lot of missed opportunities there by not studying drugs that targeted the right population. And so the trials that we do nowadays are better because of this. We can better match treatments to the tumor. So in general, we have hormone receptor positive breast cancers, which are essentially cancers that are positive for the estrogen receptor and or the progesterone receptor, and HER2 negative. This is the most common type of breast cancer in both pre- and postmenopausal women. And then the HER2, we have HER2 positive, and we can have HER2 positive cancers that are negative for estrogen and progesterone receptor, and those that are positive for one or both of those. A lot of the drugs that we use, whether the ER and PR are positive or negative, are similar, but interestingly, as even more recently, we're learning that, there are some differences in these cancers, and some of the treatments may be more tailored to that as we move forward. And then we have triple negative, and I will say I hate this name. It sounds so negative, but it's really because we're we're boring physicians, scientists, and we're not very creative. So there's 3 markers. All 3 of them are negative, and it's really telling you what it's not. It's telling you it's not one of these 3 things. It's probably not one disease. It's probably a lot of smaller diseases, and we're beginning to tease that out. And maybe some of the reasons why some of the triple negative studies have not been successful is because we weren't using it on the right type of triple negative breast cancer. So we're learning a lot about that. So the new thing is genomic testing, and it's important just to know a little bit about this. So basically, it's looking at the tumor DNA to identify the mutations in your cancer cells. So in general, we're not talking about mutations that you're born with. It's mutations that have developed in your cancer. And we know that cancers are basically a disease of accumulated mutations. Different mutations affect the cancers differently, and we know that targeting particular mutations can be successful for different cancers. So as we're really in the infancy of this, just a couple years ago, it was most patients weren't able to even get genomic profiling off of a clinical trial. It is commercially available now, although still very expensive. I'm fortunate to be at MD Anderson, where we are able to get genomic testing on a lot of our patients through our resources, but not everyone has those opportunities. There's a couple different types. So there are these gene panels, which are the most common, and this is basically you're taking a tumor, you're looking at a panel of genes that are commonly altered in maybe breast cancer, maybe cancers in general, and we're looking at just these genes, are they altered or not? And then there is whole genome or whole exome sequencing. The exome is basically the meat of the genome. So if you think of all our DNA, and there's a lot of like junk in between the genes, and so it's maybe not so important to sequence all the junk, but just sequencing the important parts, and then that decreases the cost and the time to do that test. So whole genome, which is less common, except really in the research setting, is where you're really looking at all the genes in the cancer and looking for mutations. So it's a much deeper dive than you're going to get from a panel of genes. If you go back to biology class, you have a gene, and then that gets made into RNA, and then the RNA makes a protein. And so we have genes that make proteins. We have genes that regulate other genes. There's a lot of different things that can happen. So there is an expression analysis, which is looking at the RNA. So not just is the gene altered, but is there a lot of RNA of a particular gene being made, or is that translating to a protein? How do we do this testing? So the most common way is to basically get a piece of the tissue and use that to look at the profile. What is up and coming? We're doing some of this now. It's not perfected yet, but a so-called liquid biopsy, where essentially you can get the same information from a blood draw, which is a lot less painful. It's a lot more practical. Cancer cells shed DNA into the bloodstream, and that's a way we can do this. So, and there's a lot of pros and cons of both approaches, but this is, when you're hearing these terms, this is what this means. So the uses for the genomic testing are, it can help identify treatments that might be more effective, or also treatments that probably won't work based on that. That's just as important, because you don't want to waste time on a treatment that's not going to work. Sometimes it can provide prognostic information. It might be able to identify clinical trials, and it also helps us develop new treatments. For example, if we see that patients with this gene alteration tend to respond to this drug, but then it stops working. Why? So you can get a biopsy after they're progressing and see what changed, and then maybe that can inform a new drug for patients that have progressed on that in the future. So, as we're learning more about these studies and drugs, we're learning how important getting biopsies are, or hopefully in the future just blood. It used to be that we would, like a patient may have been diagnosed with breast cancer, maybe 3-5 years later they're diagnosed with metastatic disease. And when you're first diagnosed and you have surgery, if that was the case, not everyone, some people are diagnosed right when they have metastatic disease. A lot of times you're going to have a whole tumor of tissue, so you have a lot of material that you can use for testing. And that's easier to get to sometimes than a biopsy of the new site. The problem is that as we're learning, this tumor changed. So the tumor that has metastasized is different than the tumor that was started. And so seeing how the tumor is now is going to be really important in informing the best treatment now. And even as you get treatment for metastatic disease, if a treatment isn't working anymore, there's a reason for that. And it's probably that the tumor has changed. And so obtaining a new biopsy may inform as to why that treatment isn't working and give an idea as to what we can do next about it. Right now, the practicality of doing that is very difficult if you have to get a biopsy, and not everyone has a place to biopsy. So that's another issue. A patient might be perfectly willing to even undergo surgery to get tissue, but sometimes you just can't get to it. And that's where the hope for the liquid biopsy is really going to help with that. This is just kind of a real life example to see like kind of how this genomic works. So this was a recent trial that was presented. So basically patients with hormone receptor positive breast cancer were given fulvestrant, which is an anti-estrogen therapy, and some patients were given alpelisib and some were not, were given placebo. The alpelisib targets a PI3 kinase, a very common mutation in breast cancer patients. And they also, since there has been a lot of controversy about this pathway because some other drugs that have targeted this pathway more broadly have not shown that you actually need a PI3 kinase in your mutation for it to work. And so they enrolled a patient population that had the mutation and a patient population that did not, so they could figure this out a little further and further personalize. So when the results were presented, these are some of the results. The combination drug is in the blue, and the placebo is in the orange. And so patients that had the mutation had benefit from the drug. It worked better than just doing the hormone therapy by itself. The patients that did not, the curves are almost identical. And so this is really important. We know that patients that get this drug and have a PI3 kinase mutation are likely to benefit, and we shouldn't waste our time with the drug for patients that don't have that mutation. There might be a drug that is much better for them, and we also aren't going to expose them to the toxicity of that drug. It's really complicated to navigate these trials. There's so many different types, and it can be really confusing. The trials are looking at different patient populations. So some trials will enroll a type of cancer, and it might be, depending on the type of trial, it might be patients with any type of breast cancer or any type of lung cancer or maybe just any type of cancer. They might look at the stage of cancer. So a lot of times there's different trials for patients with stage 4 disease compared to stage 2 disease, for example. one of the newer things that is happening is this new type of trial, which is called a basket trial. So on these trials, patients with cancer, it doesn't matter what kind you have. You could have lung cancer, prostate cancer, breast cancer. But if you have a PI3 kinase mutation, you can go in this trial. So some people think we're not even going to call cancers by their site of origin anymore. We're going to talk about their genomics instead. And it probably will be a combination of the two, but we're getting there. Sometimes prior treatments matter. So we know that patients that have never had any treatment for their cancer are going to probably respond different and have different types of tumors compared to patients that have already had one line of therapy, maybe a couple different types of therapy. And so a lot of times trials are targeting patients depending on where they are in their sequence of therapy. This is good for the patient also because it is looking for, there's a reason why if we are using a drug that is already in patients that have already received other therapies, this may be a more resistant tumor. This drug may be promising for that type of tumor. And then a lot of times with clinical trials, they're looking at how many treatments you have had, and this can be a part where it can be tricky to get onto clinical trials. Sometimes if you've had a lot of therapies, there's not as many clinical trials available compared to if you're very early in the treatment. And this is because we know that as the cancers are progressing through therapies, they're getting more complex and harder to treat. So just a quick note on what are the good and the bad about clinical trials, because there is good and bad. So benefits are it may provide access to a treatment that may not otherwise be available. It takes a long time to get a drug from a clinical trial to the market where everyone has it available. And this is a way to get access to the drug sooner. Of course, even if the study does not show benefit or does not ultimately lead to approval, you're still learning something about the cancer, and that's forwarding our research. Patients are very closely monitored. It's really interesting. There's been studies showing that even patients on the control arm do better than patients that are treated with standard treatment. And this is because you are monitored so closely. You have to follow very important guidelines, and you're just getting a lot of attention. So even a control arm on a study can be beneficial. A lot of times some of the treatment will get paid for, so there could be financial incentives. Other expenses are sometimes covered. The less beneficial things are you are taking a treatment that we don't know as much about, so there is some risk associated with that. And sometimes it's less convenient. Sometimes you have to do additional blood work or additional studies or do additional visits, really, so we can do the appropriate monitoring of the trial. And then some trials are randomly assigned, so you don't always get to pick which arm of treatment that you'll get. At MD Anderson, we have several working groups. Because there's so many different types of cancers, we want to try to look at and have a portfolio for early stage, metastatic disease, and the different subtypes of cancer, and have trials, for example, as the first treatment, the second treatment, the third treatment, et cetera. And so we have all these different working groups that are really dedicated to identifying trials for most of the patients that we see. In addition, we have an advanced breast cancer navigation clinic that was developed by Abby Kaler, who's done a wonderful job developing this program. Basically, after patients are seen when they're newly diagnosed with metastatic breast cancer, even if they've been diagnosed with breast cancer previously, after they've seen their oncologist, they then have a visit with Abby who really can delve into a lot of the issues, help process the information, and navigate the clinical trial and the complicated medical system associated with oncology care. And these are a lot of the things that she can address. In addition, we do questionnaires because it's really important to learn from the patients, learn how patients are feeling, what symptoms they're having, and using that to inform further research. This is the website if anyone wants information about it. So types of clinical trials. I wanted to just briefly mention the different types of clinical trials that are available. So phase 1 trials are basically, these are studies that are not previously tested in humans. These drugs have to be very well vetted before even getting to a human in animal studies and in like Petri dishes. And this is a study, so it could be a first-in-man study where this drug has never been put into a human ever, or it could be we're combining this drug with this drug, and they've never been combined before. We need to learn if that is safe to do and how to best to do that. The main goal of these studies is to determine the side effects of the trial and get the right dose. And learn about how, like, the pharmacology of the drug. Like, how often do you have to give it? When does the drug get out of your system? How does it interact with other medicines or other proteins in your body? These generally have a small number of patients. There's a lot of different ways to do this. The most common way is essentially you treat 3 patients at a time at a starting dose. You see how they do, and if things are going well, then you try to increase the dose with another 3 patients. So these patients, for phase 1 trials, you're often waiting for a slot, if you will, because you have to wait for the time point when they're ready to enroll more patients. They're getting more sophisticated. Even like 10 years ago, phase 1 trials were not very promising. They would say, we have this drug, anyone with cancer can go on it, period. But now, we're trying to enroll patients where the drug looks beneficial for your particular type of cancer, or even subtype of cancer. And some of these trials, for example, with a PI3 kinase inhibitor, you might have to have a PI3 mutation in your tumor to get on that trial. So because of that, phase 1 trials are a better option than they used to be. And a lot of them are doing like phase 1, phase 2, where as soon as they get the right dose, they're going right into a phase 2. They're not even stopping. There's a lot of different populations that can be eligible for these trials, and every trial is a little bit different. A lot of the trials will include more than one tumor type. Sometimes they're very specific, like it has to be only HER2 positive breast cancer, for example. You may hear about healthy volunteers going in phase 1 trials. These aren't really for oncology drugs, but other safer drugs, but everything has to be tested in a phase 1 trial initially. A lot of these trials allow patients with prior treatments to go on study, but they're the most uncertain because they haven't really been studied before. We don't always know what we're going to get. Phase 2 trials are where we have a phase 1 dose. We know what dose we can give. We know it's safe. And then, but we're going to try to test this in a bigger population to see if the drug looks like it's going to work well. I'm trying to move ahead a little bit so we can do some questions. And then there are some like feasibility trials that are kind of between phase 1 and phase 2. Finally, phase 3 trials. These are the trials, the big trials that are usually thousands of patients, international, and these are the ones that are really going to lead to FDA approval. these trials, a lot of times, these drugs are very, very promising. Everyone thinks it's going to work because it takes a lot of money and a lot of resources to do these. But they are randomized, so a lot of times patients can't pick whether they're going to get the drug or not. That's probably the biggest downside of it. And then phase 4 is just kind of like a post-marketing trial after the drug's on the market, trying to pick up like very rare side effects and see how it's really used in a kind of real-world setting. Just a quick note that unfortunately, although clinical trials are great, they develop, they're how we get more treatments. A lot of patients can't get on them, and there's a lot of barriers. They're either not available where they live, or they don't meet the eligibility criteria. And this is something that we would like to change. There was a task force that there were several common eligibility criteria that would exclude patients that maybe really didn't need to be excluded. And so there's now a push to try to keep eligibility criteria more open to allow more patients to go on trials. And then this is just a website that can give you more information about clinical trials in general if you're interested. Okay. So I want to give some time for questions. I went through the last bit a little quicker.
That was great. Okay, so who has questions? I know there's going to be lots of questions. Okay.
Can you talk a little bit about what some of the current challenges are with the liquid biopsies, and you said we're not there yet, but I know they're being done, so.
Yeah, so essentially, so one good thing about a liquid biopsy is that when you do a actual biopsy of tissue, you're getting just one piece of the tumor, but we know that sometimes if you have a mass in your lung and a mass in the liver, they might have developed different mutations, and so you may not be getting the full picture. So one good thing is that you're going to get like a full picture. You're going to get DNA from probably most of the tumors that are shedding the DNA. The problem is that there can be a lot of, are you sure that you're really getting the tumor DNA? Because normal cells are going to shed DNA also. So a lot of it is like sorting it. And sometimes if you don't have a big, sometimes you can't get cells. So sometimes if you do the biopsy and there's just not enough DNA floating around, you may not get enough to do the testing. I think the biggest concern is it accurate? And we're doing, there's some studies comparing liquid biopsies to tissue biopsies. They don't always match up, but that doesn't always necessarily mean that one's wrong and one's not. It might be because there's different mutations in different places. I think we are very close, though.
Building on that, what's the difference between tumor markers and a liquid biopsy?
Oh, very good question. So a tumor marker is basically a protein that is sometimes shed by a cancer. And it can, in general, if it's higher, the tumor is, or the cancer's, there's a higher burden of disease, or the cancer is more active. If it's going down, it's improving. Breast cancer doesn't have great tumor markers. Prostate cancer has a great tumor marker, PSA. We don't have a PSA. I see a lot of patients where I can see that they have cancer that's metastatic and their tumor markers are normal, and they can also be elevated for non-cancer reasons. So that's really just looking at a protein and kind of trying to get an idea of the burden of disease. It's not really going to tell you anything about that tumor other than it's there. The liquid biopsy is looking at the actual DNA of the tumor.
Hi, I think I have like two questions that are kind of related. When you were putting the different cancer types up there, I know I was told I was triple positive, so I know that's the protein and the hormones. But when I'm looking at stuff, there's never anything that says triple positive. So should I be looking at the HER2 positive as my primary, and then the hormone is just like a bonus thing that we get to treat with?
Yes.
You know?
You're exactly correct.
Okay.
Yes, the HER2 trumps the ER and PR. And so most of the trials for HER2 positive, whether it's ER positive or negative, you should look under HER2 positive. There are some that require you to be both ER positive and HER2 positive, but HER2 positive is what you would call it, yes.
And then, I'm sorry, one more question.
It's okay.
With the genomic testing, I know, so I was recently diagnosed metastatic, and they sent my tumors to Foundation One for genomic testing.
Yes.
So is that the short clip? Is that the long clip? Because they basically said that the only thing I am is triple positive. There's nothing else going on with my DNA. So is there more that I should be pushing for, should be asking for?
There's probably not much more now. So Foundation One is an FDA-approved test, which is great because now some insurance companies are paying for it. But it's one of those, the most common test where we are looking at a panel of genes. And Foundation One is pretty comprehensive. I think and I see a lot of patients with breast cancer that don't have a target or don't have a new mutation. There probably is something in there. We just aren't looking for it yet. We are really still kind of in the infancy.
I highly recommend you request a copy of it.
Yes.
So I don't know if many of you have ever seen a Foundation One report, and I think Guardant is similar.
Yes.
So it will have like a little table on the first page with all the mutations that you have, or it won't have any mutations. And then many times you will have some mutations. I've never seen someone that has nothing. What you may have is some that they have nothing for. Yeah. So there are no known treatments, but there might be something listed there that just is not being targeted yet. There might be something listed there that they have trials for, or there might be something there that you keep in the back of your mind and that you hear in like conferences like this, and yeah.
I was wondering if you could speak a little bit to immunotherapy as an upcoming.
Yeah,
because
absolutely.
we hear about that it's not responding well with breast cancer, but yet the woman was cured last year with metastatic cancer.
Yes.
And I'm also particularly interested in the PARP inhibitors that are kind of trickling in slowly. Yeah.
Yes. Immunotherapy. So one of the reasons why immunotherapy has not worked as well for breast cancer yet is because they tend not to be as messy, if you will, genomically. So if you think about like a lung cancer, it's exposed, the lung is constantly exposed to the environment every day. Like you're breathing everything in and out. And so these lung cancers tend to have lots of mutations. And that stimulates the immune system. So that's, for example, why it works so well for lung cancer. Breast cancers don't tend to be as genomically diverse in that way. And so that's why it's not been as promising. Now, if you look at all breast cancers as a whole, it does not seem to work very well in hormone receptor positive breast cancers. There is some suggestion that triple negative and HER2 positive cancers are more immunogenic, and that led to the recent approval, like yesterday, for atezolizumab for triple negative breast cancer. We are kind of also in the infancy of immunotherapy. So right now, what's happening is we're treating cancers that are already kind of immunogenic. But there are ways that we're trying to do is to make the immune system recognize the cancers more. And so we're working on strategies to doing that, for example, for ER-positive cancers where it doesn't work that well. The lady that was cured at the NCI, that was a whole different thing than what is than the typical immunotherapy that's being where you see all these like advertisements for immunotherapy. So that's not just like boosting her immune system. They basically removed her tumor, made like a vaccine just for her tumor, and put it back in her body. And it's very dangerous too. Like patients can also die from this. Yes.
So there
Yes.
were three,
Yeah.
it was
Yeah.
a basket
Yes.
trial for all cancers. There were 3 breast cancer patients.
Mm-hmm.
One died of progression, one died of the treatment and duty.
Yeah.
had a complete
So
response.
it's kind of like big risk, big reward. We're just not quite there yet, where it's safe enough to push this out.
And I would just add to that, I was lucky enough, I did Project Lead with Judy, and she was at her end of treatment. So I also want to state that she didn't think she had any more treatments left, and she just lucked out that she was at Project Lead, and there was a person from the NCI, and she went up to them after their session and talked to them, and that's why she went on. So I think that's also kind of something to be very clear about, is that she's very aware the press and the way that she's picked up on it. I just think it's important to know in here is to advocate for yourself, because that's what she did do. She was out of treatments, and she did that, because I think that's also something. But
Yeah.
Hi, I have 2 very quick questions. One, if one is being treated for metastatic breast cancer and one is very stable on the metastatic breast cancer cocktail of drugs, should one just relax with that? I mean, there's all this new stuff. Kind of one gets tempted to, I wonder if I should, look into this immunotherapy or this. Or should you just chill and relax and enjoy the fact that so far so good?
I do not advocate changing a treatment that you're tolerating well that's working. It's working, that's great. These newer things are still going to be there if it's not working.
Okay. And the other thing is, what are your thoughts about alcohol and breast cancer? I really hear different things, and of course your opinion is going to be your opinion.
Yes.
But I'm very curious.
Yeah, so it's interesting. There is really an association with alcohol and breast cancer. It's actually higher than smoking, which is surprising to a lot of people. Studies have shown, and they're not perfect because they're based on patients admitting how much alcohol they're drinking, and not everyone's honest about it. But essentially, what it appears that if you consume 3 or less drinks in a week, that's fairly safe. More than that probably does increase your risk, but probably the less alcohol, the better. Am I saying don't ever, if you're at a wedding or you're out to dinner, you should not have a glass of wine? No. I think you should live your life, but I think everything with moderation. Mm-hmm.
Follow up on that, because and there's a lot of conversation.
Mm-hmm.
There are women out there that are drinking a lot and living like 26 years. So someone without children who enjoys alcohol, like, I mean, 3 drinks is not much if you're feeling good. When I feel like crap, I don't want to touch it at all. But
Mm-hmm. It's, you have to balance everything, and we don't, like, a lot of patients ask, why did I get breast cancer? And my answer is, I don't know why you got breast cancer. There's a lot of, and life is not fair. If there's anything that this career has told me, it's life is not fair. And so I don't know why some people can go out and do everything wrong and live to 100, and other people that do everything right get this cancer. But it's just one thing that can contribute, and you have to balance it all with your social life.
Yeah, just to go back to the genomic testing a little bit. So when you have a panel that shows multiple mutations, or even just a couple, how do you decide if they're clinical trials for maybe both? Where to go with that? Can you combine clinical trials to target both mutations, or do you have to decide what's going to be the most common, or where do you go from there?
You can't go on more than one clinical trial at a time. Usually, like, that's where you're going to need some advice from your oncologist to see which mutation is probably the more important in driving your cancer.
Okay.
And some clinical trials are doing that. So, for example, there's clinical trials targeting like HER2 positive breast cancer, so they have HER2, and they also have ER or a PI3 kinase mutation. So some clinical trials are getting very specific where they are targeting more than one thing.
Right. But what about those more rarer aggressive mutations? Like I have a MYC mutation. So I wonder about that one because it tends to have a poor prognosis potentially.
Yeah, and there's a lot of trials actually looking at targeting MYC, or not even directly, but some trials, some agents seem to like indirectly help patients with MYC mutations. So I think knowledge about that helps to choose the right trial. And you don't have to understand the science. You just have to go to the right person who can help you figure that out.
Well, I'm a provider myself,
Yeah.
so I do understand some of the science.
Mine's really quick. I just, on the alcohol thing,
Yes.
when you said there's a link, were the studies done on early stage breast cancer patients or late?
We don't have good studies on it, to be honest with you. So a lot of it is like animal data and like lab data. Most of the studies are based on patients that don't have breast cancer and then develop breast cancer.
Metastatic or
just anything. Yeah. I don't tell patients they can't drink at all. Like,
Okay. Okay, so these are we have 3 minutes, and I'll definitely stay after for a few minutes. But so quick questions. Okay. Okay. So we're gonna get all 3, but we're gonna be quick. All 3. Okay. Okay. Go ahead. You can go ahead and see if you can.
Okay.
Yeah.
So I do have a couple of questions.
okay.
You mentioned the solar study.
Yes.
Are there any studies out there that are looking at CDK4/6 mutations that are similar to that? Because like I'm on iGrants right now, but I don't have that mutation, and I'm doing well. But I'm just curious.
There is a lot. We don't know what to do after CDK4/6 inhibitors right now, but there are a lot of trials that are investigating this. And like, for example, at MD Anderson, there's a lab, Dr. Kaimersi, she is looking at like resistance mechanisms after CDK4/6 inhibitors. So yes, there are studies on that.
Okay. And then I guess it kind of dovetails into that, but the liquid biopsies and, failing these drugs, and I know that they don't.
The drugs fail.
The drugs fail you.
But ultimately, I don't want to fail the drug, right? Or I want the drug to fail me. And are there ways, I guess, what is the roadmap for using things like liquid biopsies in tandem with, all the other surveillance methods that we have, to ensure that we can change medication before we, because failing means I've got cancer somewhere else, right?
So
Failing is not just an F on a report.
we don't have a good answer for that right now. That is where we hypothesize that liquid biopsies may help with that. Like, right. So if we're yeah. So it's research right now. So like we're doing a study. We're going to be opening a study, for example, where we're getting liquid biopsies and following patients for a particular mutation. And if they develop this mutation while they're on the medication, then we're going to try to target that and see if it helps or not. That's where we are. It's all theoretical and investigational right now.
It's not something that, say, I could get my oncologist to order, which he has agreed to order for me. But just from my
You could order it, but I don't know. We won't know necessarily what to do with that information.
But even though and this is one thing that kind of troubles me too, is that maybe just because the approach won't change or the treatment won't change, there's still knowledge and still data that I would like to have.
Yeah.
And confirmation, and just because you're not going to do anything different doesn't mean I wouldn't like to know.
Yeah.
Right? Is that a fair ask?
I mean, it is fair. I think if you want to get the biggest bang for your buck with these biopsies, to do it when the cancer is worsening is when you're most likely going to find something actionable. If you're doing well on the medication, then the medication's working. So,
And one risk is that if you order it now, the insurance company later could say, well, we already had it done. I think in that case you could fight the insurance and say, well, but now I really need it. I have progression. But just know that it's a risk that you're running if you get it now and they agree to pay, or you may even get it now and be denied. I mean, there are all these things that you're navigating. I think if you progress later and you ask for it again, it would be possible to fight them, but you might have to spend some of your energy on that. And if you just progressed, you might not want to do that.
Risk that I've heard about with that is, and you can comment on this, is that sometimes they don't necessarily, when you give that tissue sample up, you don't necessarily have, that's it, they can test at that time. I've run into that a lot where they're like, we want to make sure that we use the tissue sample when we absolutely need to. So it's not just an insurance issue, it's a tissue biopsy issue.
Yeah, and that's more important with the tissue. The tissue is, it's easy to get another tube of blood, but like the tissue is very precious. You can deplete that very quickly because, you know, you have just a little biopsy.
But the tissue before the progression is not the same tissue of...
And the other thing that I would say about that just really quickly is that, you know, it is still a research-based tool.
It is.
And one of the things that I've seen in some of the work that I'm involved in is that, you know, asking for a test, and maybe your oncologist might agree to, but if they're not familiar with that, you definitely don't want them to make decisions. At MD Anderson, they do this for a living as part of their, you know, specialty. But, like, you know, if you just go out somewhere who doesn't use this, there are people out in the community that are really into it, but if that's not their research focus. So I think the biggest thing I would say is if you are going to do it, to get a copy of it.
Yes.
That would be the number one,
Since you brought it up, I did try to go to MD Anderson and got denied. And so is there, should I have said something different? How can I get accepted? I mean, I felt like
What do you mean?
I mean, I think the
we can't
way
see everyone.
they definitely can't see everyone. I can give you my card and you can reach out to me. I'm in Houston. I can connect you with Abby. There's a lot of resources and things to help you if maybe there's help out.
Okay, real quick, kind of off with the triple positive, is with y'all being with you being part of MD Anderson, and it is kind of difficult for those of us who are triple positive to find resources and what's available to us. Just like triple negative and all these other things, like y'all being the starting point of having a segment just for those of us that are triple positive to find resources like what's available to us much easier, instead of having to navigate through two different kinds of diagnosis.
I would not look at, most ER positive breast cancer, like when someone says
I'm ER, PR, and HER2 positive.
So when you say, like, in the community, like in the breast cancer realm, if you say I have a hormone receptor ER positive breast cancer, we are assuming ER positive, HER2 negative. If you say, so you want to say HER2 positive, that's where you want to look a lot. So because the triple positive, the same stuff that works for just HER2 positive will work for triple positives. The difference is you can also get the ER positive drugs also. And there are some trials that are targeting the triple positives, but if you are HER2 positive, whether you're ER negative or positive, and you're looking for a HER2 positive trial, you're going to be eligible whether you're ER positive or negative.
But where I'm coming at is, like, those of us who are here at the seminar are going to know that now. But those of us who never came to a seminar prior to this, they're not going to know. And when they're looking on research, and if they go to your website, they don't know where to navigate at. And oncologists are not so freewheeling to say, hey, look at HER2 positive information. Yeah. And that's where it's like, can y'all make it easier for us to find that?
There are some online resources, like closed Facebook groups. I would encourage you to I don't even know. Is there a triple positive group? Yep. Okay.
Yeah.
Okay. Well, of course.
So, and one of the things like I just did is but I think you bring up a good point in that. I just emailed myself. I think it's something like I can talk to Abby about. Yeah. It's something I can talk to the NBC Alliance about, you know, maybe it's even just a paragraph or a one-pager. I think that's a really good point. So I just emailed myself, and I think we have a meeting with the Alliance next week, and I'm going to see Abby in a few weeks, and I think figuring out a way to just kind of, again, coordinate. So it's really important. Again, this is an example of like why it's so important to bring these things up, because if we don't know about
that's great to know.
You know, then we can go back and try to fix it. I'm not saying it's going to happen.
I mean, I've navigated it for the past almost 7 years,
right?
But it's definitely a winding roadmap to navigate.
Right.
You're right.
Try to make it easier
Right.
on newly or diagnosed people.
Yeah. Okay, last question.
And this is, I'll make this really quick. So just to, I want to, all the questions that you guys have been asking about the trials and the mutations, it's great. And I think you should really look into the MBC Connect app, which actually, you add your it's like a clinical trial matching service. I actually consult with them, so I can assure you that on the back end, we're really working to make sure that we're including, I'm the only patient that works. I'm a metastatic patient. So one of the things I'm trying to help them incorporate is actually mutations, like make sure that in the tumor. So not just are you HER2 positive, but does your tumor also show the MYC mutation or an androgen receptor or something like that? So we're really trying to make it a little bit more tailored to each patient. So if you are looking for trials, it's a really great resource. And I also do my own personalized trial searches for people. So if you have any questions, just let me know.
Awesome. I couldn't ask for that plug better. Yeah, she really hit it on there for me. As MBC Connect is really just kind of like a child of mine almost. I'm very excited for it to launch, and I think it's just another example of, I am very hopeful for the future. It is very complex. Each individual case in your own story is so complicated and so challenging, and I'm just so glad that you all came here today. So honored to have Julia here and Dr. Lehman here to speak, and for all your questions. I think it was probably the record for the most time I've ever had for Q&A in a session, so I'm really thankful to both of them for that. And with that, thank you all so much. I'll stick around for a few minutes if you have questions. And other than that, there's ways to reach out to us. We're all very friendly and open, so if you have questions or need information, please don't hesitate to reach out. Thanks a lot.